Let's see. For a maxillary incisor, generally the axis what you prepare, it is triangular axis. Okay, and this axis has to be prepared from the lingual side. And certain cases like crowding of teeth, or when the tooth is pitted too much, then only you think about a buccal axis. Otherwise, we always prefer lingual axis. And the axis preparation should start exactly at the middle part of the lingual surface. And the burr, the instrument what you use for axis, usually it is a round burr. Okay, there are two instruments with which you can do axis. One is the round burr, the other instrument is called endo-axis burr. So remember this term, endo-axis burr. Endo-axis burr has got it's almost like a tapered fissure burr which has a ball at the end. It's called endo-axis burr. I'll put the picture in your group. Endo-axis burr. So this endo-axis burr or round burr, it has to be placed perpendicular to the lingual surface when you are accessing maxillary anterior teeth. And once you get the drop, you take your burr from inside out. And variations also better learned along with this. The most important variation in anterior tooth comes in the form of a mandibular incisor. In mandibular incisor, many times 41.4%, you can see two canals, and this is more common in the lateral incisor, mandibular lateral incisor. So you have to remember this 41.4%, two canals in mandibular incisors. And this is a clinical picture which I shot using my microscope. It's my own case. All the pictures what I put in this, majority are my own cases only. This is one case in which we did a CT for an anterior tooth, and when we did the CT, because in a radiograph sometimes these two canals of the mandibular incisors won't be visible. So the only option is to go for a CT. The CT image gives a canal and a lingual canal. See, a buccal canal like this and a lingual canal like this. So that is how the canals are located in a mandibular lateral incisor. (41.5% of incisors. Okay, it is the mandibular incisors, not all teeth. Now, mandibular canine also has this tendency of having two canals, but it's only 6% of the mandibular canines that are prone to have two canals. So, in mandibular incisors are the most common in anterior teeth to have two canals. Maxillary first premolar. The cross section of maxillary first premolar in the cervical region is elliptical or kidney shaped. Okay, so the axis preparation for the maxillary first premolar is ovoid. See the shape of the axis in the case of maxillary first premolar, it is ovoid, and this ovoid axis preparation is done in a bucco-palatal direction. So usually when you do a class 1 restoration, you always go mesial-distal. But in the case of an axis preparation, maxillary premolar always has to go in a bucco-palatal direction, and the axis preparation will be ovoid in shape. And yeah, mandibular anteriors, since they are very thin teeth, if you go mesial or distal angulation with your burr, definitely it is going to get perforated because the tooth itself is very small. And after that, the next teeth which is affected by this is your maxillary premolar. Why? Because maxillary premolar, they have big crowns like this with small roots. So that junction of the crown and the root, it is very, very thin. So if you are not careful while preparing an axis in the case of maxillary premolar, then there is a chance of perforation at the cervical line. So maxillary premolars, what you do is you go perpendicular to the occlusal surface, get the drop, take your burr from inside out, and finally when you de-root, you get a ovoid axis like this. Okay. And many times your root canals are of different patterns in the case of maxillary premolars. So we have to learn those patterns as classifications. Let's come to that. And the first and the most important classification is Wien's classification. So in Wien's classification, you have type 2, type 3, and type 4. So this you have to read and somehow learn, because it's very important classification. It can come as a visual question. They can show you one particular radiograph and ask which Wien's classification does this belong. Wien's type 1 is a single rooted tooth. In a single rooted tooth, you have a single orifice and a single apical exit. Wien 2 is two root canals originating as two separate orifices. Okay, they end in one apical foramen. That is Wien's type 2. Wien's type 3 is two separate root canals. They have separate orifices and separate apical foramen. Wien's type 4 is something like your fast break. Wien's type 4 is like your fast break. Okay, so you go as one single canal, and at a particular point it bifurcates. So I always remember it like this: Wien's type 4 is fast break, so you won't forget it. Got it? Wien's type 4 is fast break. It goes as a single canal. At a particular point it bifurcates. Don't forget this. You have to learn it. It's there in your synopsis. And the tough one is nothing but your Bertozzi's classification. This you have to write it in paper and learn it, because suppose if you really want to get a seat in a government college, you have to learn Bertozzi's classification. Otherwise, you can be happy with Wien's classification. So the more complicated it is, like those will be the questions what is going to determine your rank. So I wouldn't say that I wouldn't say all of you should skip this. You have to learn this. You can learn this with a particular code. See, type 1 is similar to your Wien's type 1. So there is no confusion. Okay. Type 2 is 2 becoming 1. Type 3 is 1 becoming 2, then becoming 1. So type 2 and type 3 are almost similar. Okay, Wien's type 3 and Bertozzi's type 3 both are the same. So this problem is solved. So, and when it comes to your Bertozzi's 5, 6, 7, and 8, then you have to be careful, little bit careful. Okay, Bertozzi's 5 is 1 becoming 2. Bertozzi's 6 is 2 becoming 1 and again becoming 2. Bertozzi's 7 is 1 becoming 2, becoming 1 and again 2. And Bertozzi's 8 is very peculiar, 3 separate canals. So this is not very tough. If you actually see this picture and learn it in comparison with your Wien's classification, Bertozzi's classification is also simple for you. So these are certain things which you have to keep in your mind while you are doing your entrance preparations. You have to be a visual learner. You have to be a learner with a lot of codes. You have to be a learner with a lot of numericals. So the more you repeat this, the more you see these videos, the more you see these slides, the more you see pictures in textbooks and guides, the more you learn. So don't take any shortcuts, because 1 year from now you will be appearing for the exam, and make sure that you are thorough with all the subjects within 8 months. Before, once we end our class sessions after 32 weeks, you will be having a lot of revision months. We will be helping you for revision also. Okay, you all will be put in mentorship batches. All of you will be divided and entrusted with one faculty member who is going to take you through this entire year. He will be, or he or she will be like your class teacher. And our class teachers are always bothering us. They will bother you, because bothering without somebody pushing, we won't learn. Not because of anything else, it's a competitive exam. So that has to be there. So please don't feel bad if your mentor keeps pestering you why you didn't score good marks in this test paper like that. Don't worry, like that's a part of the game. Okay, if at all if you feel really bad or anything, you can personally message me, not a problem. Yes. So coming on to the maxillary premolars again. So the maxillary premolars have different types of root canal patterns, as we saw in Wine's classification and Bertuzzi's classification. So in the case of a mandibular premolar, many questions have been asked from mandibular premolar. Mandibular premolar, your mandibular crown always has a lingual tilt, and this lingual tilt is more for the first premolar than the second premolar. So mandibular first premolar is generally known as the enigma to the endodontist. Why? Because it has a lot of complications. Many times that Wine's type 4 is more seen in this mandibular first premolar. Lot of bifurcations and trifurcations. Coming on to the maxillary molar again. So mandibular premolar is very peculiar with its tilt, lingual tilt of the crown, okay, and the different bifurcations and trifurcations. Coming on to the maxillary molar. Maxillary molar, generally the access preparation for your maxillary molar, it is triangular in shape. Why it is triangular in shape? Mainly because maxillary molar has 3 roots, and 3 roots, it generally has 4 canals. How come 3 roots and 4 canals? Your mesiobuccal root of the maxillary molar, it is flat, and so this flat mesiobuccal root of maxillary molar can contain 2 canals at a time, and that is your MB1 and MB2. And you might ask me whether this MB2 is that important. Unfortunately, MB2 is seen in 95.2% of all maxillary molars. That means that you have to search for it. Okay. And the largest canal in the case of a maxillary molar is your palatal canal. Palatal canal is the largest root and the largest canal in the case of a maxillary molar. And the tooth which has the maximum volume of pulp, that is also your maxillary molar. That means that your maxillary molar is a headache for everyone, not only for the patient but also for the clinician also. So remember these things. Maxillary molar, the axis is generally triangular. Why triangular? Because it is having 3 roots, and these 3 roots are the mesiobuccal, distobuccal, and the palatal. They are, when you see the dentinal map, what is a dentinal map? When you open a pulp chamber, what you see on the floor is the dentinal map, and the dentinal map is the junction of your floor and your walls. And in that dentinal map, that particular shape of the dentinal map is triangular. So when you deroof it, automatically you have a triangular axis. And in this triangular axis, you can see 4 canals instead of 3. Why? Because your mesiobuccal root has got an additional canal called MB2. MB2 is also known as MP. What is MP? Mesiopalatal. Okay. And the most difficult canal to locate in a maxillary molar is your MB2. So why MB2 is that important? Because in a radiograph, you might not be able to see an MB2. Why? Because when you shoot a radiograph from the buccal and capture it from the palatal, many times your MB1 and MB2, they overlap. Only in a CBCT, or when you see a particular tooth from the mesial view, you will be able to distinguish between these 2 canals. So this particular picture, what you see on your right side, is something which you don't see in your routine radiographs. This can be seen only in a CBCT. So that is the importance of MB2. And the majority of MB2, they are of Wine's type 2 pattern. Or Bertuzzi's type 2 and 3 patterns. They might be having 2 canals which join and have a common apical exit. That is the reason why even if you don't pick an MB2, the tooth survives for some while. See, many times your MB1 and MB2 joins together, okay, with an apical exit. But that is not true for all the teeth. Some teeth have 2 separate MB1 and MB2. So what do you do for such teeth? You don't have a choice. If you don't treat those MB1 and MB2, that particular case might go for a failure. So that is the importance of mesiobuccal, second mesiobuccal canal in the case of a maxillary molar. Now, when it comes to a mandibular molar, okay, the axis preparation is either triangular or trapezoidal. More correct answer would be trapezoidal, I would say, not triangular. But in some guides, older question papers, they have given triangular. Triangular is only when you have a single distal canal. But 30% of mandibular first molars have two distal canals. So how many canals totally? 4 canals. Mesially you have mesiobuccal, mesiolingual. Distally you have distobuccal and distolingual. So when a mandibular molar has 4 canals, then the axis would be trapezoidal. Why? Because the dentinal map shape is like that. And one more thing, in the case of a mandibular molar and even the maxillary molar, the mesiobuccal canal will be positioned directly under the mesiobuccal cusp tip. Mesiobuccal canal will be positioned directly under the mesiobuccal cusp tip. Mesiolingual canal will be directly under the central groove. So your axis preparation will be more buccally placed in the case of a mandibular first molar. What is radix entomolaris? Sometimes, rarely in the case of a mandibular molar, it's very rare, okay, you might get an extra root in the lingual side of the mandibular molar. Okay, usually distolingually. See, this is how you see a radix entomolaris. Okay, so this can come as a picture question, so be careful about it. Then you have radix paramolaris. That is, if that particular extra root, it will be very small, but it will be having a pulp tissue inside that. So it's very important. You cannot miss it. You cannot afford to miss it. If that particular extra canal is located at the middle of the mesial and distal roots on the buccal surface, it is known as radix paramolaris. So usually radix paramolaris will be seen at the buccal surface. Radix entomolaris will be seen distolingual. Okay, so this particular question was asked in the last NEET exam about radix paramolaris. What about C-shaped canals? Yes, sometimes you will be able to see C-shaped canals like this. The canals are not round in cross section. They are C-shaped or kidney shaped, sometimes bean shaped. There are a lot of terminologies for that. So these C-shaped canals are usually seen in mandibular second molar. And even there is a classification for the C-shaped. There is a classification given by Melton. Okay, one more classification is there, which is much more latest. I just put this Melton. See this Melton's classification in the synopsis. If your C-shaped canal is continuous as a single canal from the pulp chamber to the apex till the apex without any divisions in between, then it is Melton's classification class 1. If the C shape separates in between and forms additional canal in between, then it is class 2. If the C shape has orifice with 2 or more distinct separate canals, along with the C shape, you have more canals, then it is class 3. So sometimes some visual questions might come like this. See, asking which classification does this C-shaped canal belong to? This is a type 2 C-shaped canal. So such kind of questions you can expect for your exams. Now, what do you mean by accessory canals? Are more common in the apical 1/3 and furcation areas. What is an accessory canal? Accessory canals, they are the ones which are abundant, which are in more numbers, and it is seen at the apical region and furcation areas. And how is it different from lateral canals? Lateral canals are the canals which are running perpendicular to the main canal. Suppose if there is a canal which runs 90 degrees or perpendicular to the main canal, which is wide enough, thick enough, then you call it as a lateral canal. Accessory canals are thin canals. Okay. So that is how it goes. The tooth with maximum number of accessory canals in the bifurcation area is the maxillary first molar. Now, let's come to the questions. Now, incidence of two canals in mandibular incisor. It's an AIIMS question. Yes. Answer is C. Correct. 27. A divided I'm happy that all of you are following because you are able to answer the questions after the micro sessions only if you attend to the sessions. Yes, very good. Very good. All these numbers, please do write down in your pocket books. And when there is 3 canals in a premolar, it's very rare. Okay, only 6% of premolars have this 3 canals. Which is the root which bifurcates? It will be the buccal root. Always remember. It is similar to your maxillary first molar. The buccal root will be having 2 canals. Palatal root will be single. Always remember that. It's a very direct question. At the cervical third of a premolar, maxillary premolar, what will be the shape? It will be elliptical. Good. Bifurcations. Why somebody is called the enigma to the endodontist? Because there are a lot of bifurcations and trifurcations. Fast break. Remember, fast breaks are Wines type 4, right? Type. Bifurcations of the canals. I told the largest root canal in maxillary first molar is palatal. Even the longest root canal is also palatal. It has the maximum pulp tissue also. See, specifically they have asked 4 canals. That means that the answer should be trapezoidal. Radix endomolaris is seen in mandibular first molar. C-shaped canals are found most commonly in mandibular second molar. This is an indirect question. You might get a pulp exposure in your class 1s and class 2s. If you make the pulpal floor perpendicular to the long axis of this tooth, we told no, mandibular first premolar, what happens? You have the crown with a lingual tilt. So if the crown has a lingual tilt, naturally it has a tendency to get a pulp exposure. This was asked in Kerala entrance 2016. You tell like C-shaped canal, bean-shaped canal, kidney-shaped canal and all. Which section is it? It's basically in the cross section. What's the answer? Straightforward question, simple one, perpendicular to it. MB2. Yes. 95. Invasive cervical resorption. This came in PGA 2018. Okay, because usually such questions are PG level questions. Nowadays they are asking PG level questions for entrance examination. Invasive cervical resorption close to the pulp chamber without extension into the radicular dentin. Remember, without extension into the radicular dentin, but close to the pulp chamber. A is not the answer. I think many of you got confused. We'll go back to that. A means invasive cervical resorption has just started. It has not. It has got a very good prognosis. It has not reached the near to the pulp chamber. B means invasive cervical resorption started, but it has not entered the root, but it's still in the crown, but it has reached almost the pulp chamber. Class 3 means invasive cervical resorption started from the coronal region, but it has extension into the root, but not beyond coronal 1/3. Class 4 is the invasive cervical